So I'm going to be talking about some research that we've been doing using the IDI to look at service use in multiple sclerosis. And this research was commissioned by Multiple Sclerosis New Zealand and funded by the New Zealand Multiple Sclerosis Research Trust. So multiple sclerosis, or MS, is an autoimmune disease which affects the central nervous system. That is the brain and the spinal cord. MS is quite a heterogeneous disease. It can affect people quite differently. As you may imagine, there can be a range of neurological symptoms, things like issues with balance, vision, motor control, as well as things like profound fatigue and cognitive dysfunction and mood issues. MS is most commonly diagnosed in women, and it's commonly diagnosed in working age, so it can have large impacts on career trajectories. And the cause of illness can vary quite a lot across individuals, and this is especially the case with increased access to highly effective drugs that disease-modifying therapies that reduce the progression of MS and the accumulation of disability. So this research uses the IDI. So I need to show you this disclaimer, which basically just says that the data was provided by StatsNZ under conditions to maintain data confidentiality, and that the results of the work of the authors, not StatsNZ, and it's not official statistics. So if anyone's seen me present on the pilot study, we classified a cohort of people likely to have been diagnosed with MS based on service use across a range of health data sets. So that was having hospital discharge records with a principal or secondary diagnosis of MS, pharmaceutical dispensing of any of the 8 funded disease-modifying treatments for MS, flags for MS in the inter-eye needs assessments for older adults data, and the disability support services data. And we found that that cohort was sort of broadly representative of what we would expect to see based on previously published research in New Zealand. For this study, we added an additional source of data, MSD incapacity data, and this increased the size of the cohort somewhat. And this people identified from this data source were generally similar to those identified from health data sources, but a slightly greater proportion were men and Maori in Pacific. For this research, we limited the cohort to people with a record of MS by the 31st of March 2023, and who were resident at that date. And for this presentation, I'm going to focus on looking at patterns of service use over the next 12 months for 3 different areas: specialist appointments, allied health, and other health services from the National Non-Admitted Patient Collection, disease-modifying treatments, and income support using the MSD Income Support Payments Code module. And I'm going to show some results by age group, health district, and socioeconomic position. So we identified 5,634 people, of which the vast majority were adults. All the rest of the data in this presentation relates to adults. Most people were identified from publicly funded hospitalizations. Notably, quite a large proportion were identified from MSD incapacity data, and 10.6% of the data of those in the cohort were only identified from MSD incapacity data, so that added quite a substantial number. But most people were identified from at least 2 sources, which is reassuring. So this slide shows the estimated prevalence by health district. On your right, there's the crude rates per 100,000, and on the left is the age standardized rates. First thing to note is that the values for Capital Coast and Hutt Valley are combined, so those are always going to be the same throughout the talk. And we can see that the prevalence of MS is greater the further south you go, generally. And this pattern has been seen in much research in New Zealand. We did find a slightly lower rate for Auckland and Counties Manukau, which is in opposition to what was seen in the 2006 prevalence study, where there were greater rates for Auckland Health Region than for Northland and Waikato. So we're not entirely sure what's going on there. It's sort of an area for further research. So here's some descriptives of the MS population. There's 2 key things I'd like to take away from this slide. So the first is that some health districts are really small. So when we're looking at rates of service use for those areas, we need to be really careful about not over-interpreting. And that's particularly in the case with all these figures have been random rounded to base 3, which adds a lot more noise to the smaller health regions than the larger ones. The other thing to be aware of is that health districts will vary in many characteristics that will also be related to needs for health services. So any of the differences we see might be due to differences in service provision, but they might also relate to differences in needs across the health districts. Age being a particularly important characteristic, particularly as younger people are much more likely to be eligible for disease-modifying treatments. Here we've got just the working age population, employment status and earnings, and we can see that among the working age population, a greater proportion of people with MS are not working than for the total population, so 38.4% versus 20.6%. We can also see that earnings are lower for the MS resident population, as you would expect. However, when you break that down further by age, the older age groups, the patterns between the MS resident population and the total resident population diverge much more than for the younger cohorts, which is likely because older people have lived with MS longer on average and accumulated more disability, but also because the younger cohorts are more likely to have been treated with disease-modifying treatments. So hopefully what we'll see going forward is that younger cohort, as they get older, will have outcomes that are more similar to the total resident population. Here we've got neurology appointments, so that's the rates of having at least one publicly funded neurology appointment during the 12-month period. And we can see that 39.1% of the MS population had at least one publicly funded neurology appointment, compared to 0.6% of the total population. However, despite the large differences in the absolute rates, the relative pattern is quite similar for the two populations, suggesting that this is possibly driven by access to neurology care for the population overall, rather than to do with how health districts are managing MS-specific aspects of care. And we can see that there's particularly high rates for Capital Coast and Hutt Valley, and particularly low rates for North and South Canterbury and Wellington. If we look by socioeconomic position, we can see that people with higher levels of socioeconomic position were more likely to have received a publicly funded neurology appointment. However, when we look for the total population, we actually saw the reverse pattern. So for the total population, people with lower levels of socioeconomic position were generally more likely to have received a neurology appointment. So we worked with MSNZ to identify a set of allied and other health services that were likely to be particularly relevant to the MS population. And we can see that for these services, people with MS were more likely to access these services than for the total resident population. However, MSNZ has communicated that these rates are still a lot lower than what the level of need is among the MS population, particularly for things like speech therapy. So in the interest of time, I'm just going to present on physiotherapy. I was going to present on a few more. But what we can see is patterns are quite similar still for the MS resident and the total resident population, although not exactly the same. We can see higher rates for Nelson Marlborough, South Canterbury and Whanganui for both populations, and lower rates for counties Manukau, West Coast and Hawke's Bay. When we look by socioeconomic position, we actually see the opposite pattern to what we saw for neurology appointments. So we're seeing that people with lower levels of socioeconomic position were typically more likely to have received publicly funded physiotherapy appointments. And that was a pattern we saw for all the health services, other health services we looked at that had it. So we looked at those with at least 10% of the MS resident population having received the service. And here we've got the distribution in the heat map. We've got the proportion that received any DMTs within the 12-month period. And on the left, we have the percentages that received high efficacy DMTs. So those are the monoclonal antibody treatments, which are given by infusions, typically in hospital settings. And those are the drugs that really can have a big impact on the progression of MS. And what we can see is that there's quite big differences in the rates, both of any DMTs and high efficacy DMTs. Particularly, we're seeing higher rates for the 3 Auckland health districts, for Capital Coast and Hutt Valley, and for Southern, while we're seeing lower rates for Bay of Plenty, Nelson Marlborough, West Coast, and to a lesser extent, Northland, Tairāwhiti, Wairarapa. Notably, the numbers were too small to look at efficacy across all the health districts, so that's why some of those are missing from the table. In general, health districts that had younger populations had greater levels of receipt of the high efficacy DMTs and any DMTs, as you might expect, but also tended to have a large hospital within those regions. So we need to sort of disentangle what's leading into those rates, and also to some extent they match up with the patterns by neurology care, which we might expect because people are likely to need to access neurology care to be able to access DMTs, but also people on DMTs are prioritized for neurology care because we need to manage the potential adverse events that can happen with these drugs, and also because the focus on scarce resources on people who are most likely to benefit. But that's not to say that people who aren't on DMTs wouldn't also benefit from greater access to neurology care. If we look by socioeconomic position, we see a similar pattern as we saw for neurology, where people with higher levels of socioeconomic position were more likely to receive those high efficacy DMTs. So none of the analyses I've shown you here have controlled for in fact, it's partly because of the small counts. However, we did do some analyses which have just been published looking at ethnic and socioeconomic disparity in dispensing patterns, and those did show pretty clear evidence of socioeconomic disparities. So that's a bit of the reference if anyone's interested. Here we've got some rates of benefits for comparing people with MS and the total resident population. And one of the key takeaways from this slide is that 19.1% of people in the MS population received the supported living payment for a personal health condition during that period, compared to only 2.7% of the total population. However, rates of job seeker benefits, including the job seeker help, are actually lower for the MS population, which seems to suggest that the chronic and long-term nature of MS is being appropriately taken into account when people are accessing income support. People with MS also received disability allowance, accommodation supplement, and one-off payments at greater rates than for the total population. Although notably, these rates are likely to be underestimated because supplementary payments are only paid to one member of the household when there's more than one member of the household on a bed. But that's just something to keep in mind. So quickly, some strengths and limitations. So first of all, the use of the IDI provides us with all the population data, which allows us to look in detail at service use for a small population, and allows us to track trends over time and understand patterns. But there's some important limitations that we need to consider. So first of all, this cohort will miss people with diagnosed MS who have not interacted with the health services captured by the IAM, or with MSD, and who have not received an MSD benefit in relation to the MS. It'll also miss people who haven't been undiagnosed, and that might be differential across groups due to difficulties in accessing healthcare. And we'll also capture some people who were misdiagnosed at some point and then later diagnosed with a condition that better fit their clinical picture, or who just had MS incorrectly recorded in their records. And we don't know how many people that applies to. We also don't have any information on MS subtype, and that's important because that affects disability progression, varies across subtypes, as does eligibility for DMTs. So there's only one funded DMT for people with primary progressive MS, and people with secondary progressive MS can't access funded disease modifying treatments. And the last thing to note is that most of these analyses were only bivariate relationships, so it's really important to consider local contextual factors. So we're going to be working with MS embed to sort of disentangle what's driving a lot of these patterns. However, there was evidence of quite stark differences in service use across health districts and levels of socioeconomic position, and this was especially the case for neurology appointments and disease modifying therapies. Employment-related outcomes were typically poorer for people with MS, although the differences were smaller for younger people, and there was greater receipt of income support, especially the supported living payments. So I'd like to acknowledge New Zealand Multiple Sclerosis Research Trust and Multiple Sclerosis New Zealand for funding and commissioning this research, StatsNZ for providing access to the IDI and their support throughout the project, and of course the IDI checkers who have been wonderful throughout, the PPI, and thank you all for listening.
You found a lot of the people through MSD data, obviously, and then you had a look at that income and then also the type of benefit that they're on. I'm wondering if you had a look separately by just like removing the people that you found only through that source as well, and just kind of like having a look at that, because obviously that seems like if they're not found through those sources, there might be other sources that you're missing, and so it might be kind of like unduly biasing those parts.
Yeah, that's
also hidden other ways that you could find out if they have them in the population.
Yeah, that's a good point, and we should consider looking at that. That's what we did for the analyses of pharmaceutical dispensings in that paper, was we excluded people who were identified from that pathway. Yeah, the MSD benefit was at any point in the history, but yeah, it would be worth just excluding those people and seeing.
Just if they were on SLP, which a lot of them are, there's not much on and off.
Yeah, that's right. yeah.
Have you been able to map it through, sort of maybe leading to longitudinal, to older people who've had MS through their life, and that's still now once they get into that older age group with other conditions, which could be related to it and the impacts.
You mean on their service use, or you mean on
on how they're treated, how the the relationship with to not just being the MS but the other condition, or the other condition and then MS, and then being able to be equalised.
Yeah. So looking at comorbidities was beyond the scope of this project.
Potential.
Yeah. I mean, with funding.
With funding. Yeah.
I think that's the answer to a lot of things today.
This is another question that I think will fall into the category of scope creep. In terms of the DMTs, I was wondering if there was kind of, in your analyses, if you had any comments about how quick New Zealand is to kind of utilise some of these therapies. I mean, the one that I see ads for now all the time is like Ozempic, which has its own story. But yeah, GPs and neurologists, are they, if there is a new treatment available in New Zealand, are they quick to prescribe it? Do some doctors kind of have hesitancy?
So I shouldn't comment on that too much. I'm not a clinician. What I have heard from a clinician we work with is that there are some neurologists who are much more focused on MS.
Gotcha.
And then that's likely leading to some of the patterns we're seeing in some regions, is that it's less access to neurologists, and so neurologists and less access to sort of escalating to those newer treatments. So possibly more people staying on the lower efficacy treatments when they could move to higher efficacy treatments because of not being able to access neurologists that are well informed and confident to prescribe those newer treatments, which also can have pretty significant adverse effects.
Did you look at any time series of DMT dispensations?
No, not for this project. Yeah, we did look at employment over time, and there is a really interesting, just a gap between after 2014, where there's just higher employment after DMTs become more available. And I can't say it's because of that, but really like to look into that further.
More funding.
Yeah.
If anyone knows anyone.
Can do no, but there's no way of identifying people who have private health insurance, and
I'm aware of.
No, we can no, because I wondered if that could be why.
We can look at their private hospital use.
Yeah.
Yeah, so you can access to neurologists if you've got private insurance. You can access.
I mean, it's interesting because that neurology pattern, we're seeing the opposite thing to what we're seeing for the allied health services. So it's, people with higher levels of socioeconomic position, more resources to see private neurologists are seeing them on the public system at greater rates than people with less resources.
This is just a quick one. I don't know, is there availability in the occupation codes? Is it neurologists and occupation code that you could find through the census and then look at their employer and find out what region their employer is in? So you could see the number of neurologists in each region?
I've seen data that has tried to do that, and it has resulted in like significant undercounts of different professions when they've used.
Nobody currently knows how many neurologists are employed in New Zealand. Fiona and I are part of the Neurological Alliance, and we've been working with the other member organisations to try and figure this out. Fiona knows a lot about it, and nobody knows. The government doesn't know, the Ministry of Health doesn't know.